So the topic today is analyzing DAPA-CKD, an in-depth review of SGLT2 inhibitor data on renal protection. And it really gives me great pleasure to introduce David Cherney. Many of you will remember some of his earlier talks before any of the trials were done, where he taught us about the mechanisms of SGLT2 inhibitors. But importantly, he's currently a senior scientist at the Toronto General Hospital Research Institute. He's a PhD in human renal physiology and at the University of Toronto, and is a professor in the Department of Medicine at U of T and a clinical scientist at UHN and Mount Sinai. He's also the director of the Renal Physiology Lab, and he has been a recipient of the Kidney Foundation of Canada Scholarship Award and then a 3-year Crescent Fellowship. He currently holds a 5-year Canadian Diabetes Association Joint New Investigator Award, which has been recently completed, and receives a number of really impressive grants from operating funds from CIHR, Diabetes Research, Kidney Foundation, and the Diabetes Associations. And David, it's really a great pleasure to be able to have you give us this talk. I want to just, next slide, acknowledge that we are hosting this session in Vancouver on the unceded and ancestral territory of the Coast Salish peoples that includes the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, as well as the Métis chartered community of the Lower Mainland region. And around this province, 37 participants are in their territories. And with that, I will happily turn it over to you, David, to help us with this province-wide rounds. Thanks again.
Thanks, Adira. Thanks for the lovely introduction. And from my part, we acknowledge that we're hosted on the lands of the Mississaugas, the Anishinaabe, the Haudenosaunee Confederacy of the Wendat, and we also recognize the enduring presence of all First Nations, Métis, and the Inuit peoples. So I'm going to share my screen now. And can you see that okay?
Absolutely. Perfect.
All right, so welcome everybody. It's a pleasure to speak to you this evening about this really exciting area, and specifically this extremely exciting trial that is quite new to the cardiorenal metabolic world. And so I'm going to take you through DAPA-CKD specifically this evening, but I will give you some background beforehand just to tell you about my my impression about its place within the context of other trials that have come before it, and we'll talk about what's going to come after DAPA-CKD as well, and have a little look to the future. So these are my disclosures, and importantly for DAPA-CKD, which was funded by AstraZeneca, I've acted as a consultant for AstraZeneca and for all of the companies in this space. And I've also received operating funds for DAPA-CKD, for Credence, for EMPA-KIDNEY, and a variety of cardiorenal metabolic trials that are either industry sponsored or that are investigator initiated to try to help and improve the health of people living with type 1 diabetes, with kidney disease, or heart failure. So by way of objectives, we're going to talk about the SGLT2 inhibitors, and I will tell you a little bit about some of the mechanisms that are involved with these therapies. I'm not going to focus on that though. I'll move on quickly to the clinical trial evidence that illustrates the primary role of the kidney, and then talk about some of the emerging evidence in people without diabetes, and as I mentioned earlier, talk about some studies examining renal endpoints. So this talk will, I hope by the end, convince you that these are truly renal drugs, and that all of us have to be very comfortable with their use across a range of indications, including glycemic control, including kidney protection, and including protecting against the development and progression of cardiovascular disease. So this is where we've started, and I was giving a talk at the Jewish General Hospital virtually this morning in Montreal, and I did my training there, and I was sort of thinking about what I used to do when I was a medical student for the treatment of kidney disease when I was in my internal medicine longitudinal clinic. And essentially what we used to do, this is now 20 years ago, is to focus on glycemic control to lower blood pressure to reach the targets that we have in our guidelines, and to use ACE inhibitors or ARBs to treat people with albuminuria. In addition to that, we have for a long time used therapies to reduce cardiovascular risk factors, such as statins. But really, this is all we've had for that entire couple of decades since the publication of the IDNT and Renal trials. And these are the seminal trials that we've sort of based all of what we do in nephrology on, especially in people with diabetes and kidney disease. We've used the Renal and IDNT trials to reduce renal risk and important composite endpoints that include significant GFR decline, renal replacement therapy, and mortality. But I think it's also important to recognize that despite the use of ACE inhibitors or ARBs, that patients have still had a significant residual risk of developing those primary endpoints over time. So these therapies are incompletely effective, and patients still have a lot of risk of developing endpoints despite the use of these therapies. And similarly, in people with non-diabetic kidney disease, shown in blue on the far right-hand side, the RAIN trial provided evidence that ACE inhibitors reduce risk as well, but again, patients still have residual risk of developing those endpoints. Now, those were landmark observations and has formed a foundation for what we do in clinical nephrology, but it's also important to recognize that in many areas, the use of these therapies is not what it should be. And so in this example from the Cure CKD registry in the US involving more than 600,000 people, Kathy Tuttle reported last year that only about 20% of patients who are eligible for the use of an ACE inhibitor or ARB for a clinical indication actually receive them. And so the prevalence and use of RAS inhibition remains unfortunately quite low, and Canadian data has similarly shown that we are not reaching all of the patients who need to be treated with these foundational therapies. And what's also kind of disappointing in this analysis is that she reported that the use of NSAIDs, which are of course renal toxic, was about 20%, and the use of an ACE inhibitor or ARB was similarly about 20%. So this illustrates how much work we have to do in our field to better treat our patients. So this brings us to the SGLT2 inhibitor area, and I'm focusing on SGLT2 inhibitors because they're probably the most advanced of the new therapies that have come out over the last 5 years. There are other areas of interest, such as GLP-1 receptor agonists and mineralocorticoid receptor antagonists, and we can certainly talk about those towards the end, but this is certainly the area that's the most developed and advanced in terms of new therapies in this field. So the SGLT2 inhibitors, of course, work by blocking the reabsorption of glucose and sodium at the level of the proximal tubule, and in doing so, lead to a glucosuric effect, which lowers A1C and weight. And that's why these therapies were originally approved, as for a diabetes indication, a metabolic indication. But in addition to that, these therapies also induce a natriuresis, which triggers a variety of other ancillary benefits through blood pressure lowering, changes in albuminuria, GFR, plasma volume, and other effects that I'll discuss as an overview in the next slide. So there are many mechanisms that have been linked with kidney protection with the SGLT2 inhibitors. And these include mechanisms around kidney protection at the top by protecting the heart. So these therapies are cardiac protective, and so in doing so, if you protect the heart, you can also preserve renal perfusion and prevent against kidney disease progression through, for example, ischemia. They also reduce blood pressure and improve metabolic parameters, which also may reduce renal risk over time. These therapies reduce ambient pro-inflammatory and pro-fibrotic factors by suppressing mediators such as interleukin-6, for example, which has been implicated in the progression of diabetic kidney disease. And at the bottom, these therapies also reduce hypoxia in the kidney through a variety of mechanisms, both through increasing hematocrit and also by by having a sort of a kidney beta blocker effect, whereby blocking the requirement that the kidney has to reabsorb all this solute, all the sugar and salt that's delivered to the proximal tubule. By blocking that reabsorption, it's thought that there is a reduction in the consumption of oxygen, thereby reducing ischemia in the proximal tubule. So it's sort of like a beta blocker acts at the level of the heart by slowing down cardiac activity. These agents also reduce albuminuria, and they also reduce the need for other therapies like loop diuretics that tend to be deleterious at the level of the kidney by causing volume depletion and pre-renal failure. So these therapies have all of these effects that make, in sum, contribute to renal protection. And finally, they reduce intraglomerular hypertension, which may also be important, this ACE inhibitor-like effect that these therapies have by inducing afferent constriction, which reduces renal hyperperfusion and reduces renal hyperfiltration. So how is it that these therapies impact on renal hemodynamic function? So there are a variety of mechanisms that may be involved. This is the most well-studied and the area that's been looked at probably in the most detail in animals and in humans. And the idea is that by blocking this proximal reabsorption of glucose and sodium, this leads to an increase in sodium delivery to the macula densa, which is, of course, downstream. And by increasing the delivery of sodium, this essentially triggers more salt reabsorption at the level of macula densa cells, which breaks down ATP to adenosine. The adenosine, in turn, binds to the adenosine 1 receptor. And in doing so, adenosine acts as a vasoconstrictor. And so this vasoconstriction leads to a reduction in renal blood flow and GFR, which essentially normalizes the physiology in people with diabetes, especially early in the course of the disease, which has been linked with hyperperfusion and hyperfiltration. And so by constricting the afferent arteriole, this normalizes this state of intrarenal hypertension, which is probably responsible for the reduction in albuminuria with these therapies, and responsible for decreased hyperfiltration, and also responsible for this characteristic dip in GFR that we see with these patients, with these medications in patients with diabetes. And I'll also show you data in patients without diabetes where the same mechanisms are triggered. So this is some proof that sort of illustrates this effect on the afferent arteriole by Kengo Kitakoro and Naoki Kashihara's group. And they showed that in vivo, in the Akita type 1 model of diabetes, that this is an alive animal that's anesthetized with essentially a powerful microscope that sits on the surface of the kidney and can visualize cortical nephrons. And you can see that this is an untreated animal with a dilated afferent arteriole. And by giving empagliflozin in this case, the afferent arteriole constricts, and that reduces intrarenal hypertension and hyperperfusion. So this is an acute effect. And in humans, we've shown in children with type 2 diabetes that even after a single drug, there is a hemodynamic effect, and a single dose of a drug. For one day, there is this renal hemodynamic effect with these therapies. So in these animals, you can see that there was this acute effect on reducing single nephron GFR of around 30%. And in addition to that, there was a significant reduction in the diameter of the afferent arteriole. And this illustrates this very nice afferent constrictive effect. So we think that these therapies predominantly induce afferent constriction, and that reduces hyperfiltration, as opposed to a RAS inhibitor, which essentially dilates the efferent arteriole, which also reduces intrarenal hypertension. And so in DAPA-CKD and Credence and the other trials that I'll mention, patients were generally on a background of one of these therapies that dilated the efferent arteriole, and then in response to administration of an SGLT2 inhibitor, there was a constrictive effect at the afferent arteriole, which normalized intrarenal hemodynamic function. Okay, so that's mechanisms. We've talked about changing hypoxia, intrarenal hemodynamic function, and the changes on inflammation and fibrosis, all of which may be important. Regardless of the mechanisms, however, there are significant clinical protective effects with these therapies. And this is one of the most often quoted meta-analyses that's looked at the renal clinical effects that are beneficial with the SGLT2 inhibitors. And in this meta-analysis by Brendan Nguyen, who's based in Sydney, Australia, who reported that the effect of SGLT2 inhibitors in the different cardiovascular outcome trials like DECLARE, CANVAS, EMPA-REG OUTCOME, and CREDENCE, there were benefits across the range of GFR that's been included in these trials. So GFR of more than 90 at the top, GFR 60 to 90, 45 to 60, or less than 45. There were significant reductions in the composite of end-stage kidney disease, substantial loss of GFR, or renal death across the spectrum of kidney function that's been included in these trials. And interestingly, if anything, there was the biggest reduction, which you can see at the top, in the patients with GFRs of over 90, with a risk reduction of around 63%, versus people with GFRs of less than 45, where there was still a very substantial effect, but only a reduction of 30%. And interestingly, when they did a statistical analysis to compare these hazard ratios, there was actually a significant p-value for the interaction across these hazard ratios. In other words, this hazard ratio is significantly lower than this hazard ratio, which illustrates this sort of paradox that the healthiest patients in these trials shown above with GFRs of over 90, they had the most benefit in these trials, which is a little bit the opposite to what we would perhaps expect. I would have expected that the sickest patients, those with low GFRs, would benefit the most, but this analysis suggests the opposite. So there is more recent data that's been published. So I'm fortunate to be on the steering committee for VERTIS CV, which looked at ertugliflozin, and we reported some of the renal and cardiovascular data at the ADA, and it's recently been published. And in the primary paper, and at the ADA presentation, we reported the key renal outcome in VERTIS CV, which was renal death, dialysis transplant, doubling of serum creatinine from baseline. And we were a bit surprised to see that the effect of ertugliflozin did not reach statistical significance. So it crosses the line of unity, as you can see, compared to the other trials, which did have a significant reduction on the key renal outcomes involved in those trials. But importantly, if we look at this in a bit more detail, across the different trials, there were actually different definitions that were used. The doubling of creatinine in EMPA-REG OUTCOME. In VERTIS CV, we also used a doubling of creatinine, whereas in CANVAS and DECLARE, they only used a 40% decrease in GFR. And to remind you, a doubling of creatinine corresponds to a 57% reduction in GFR. So it's a much higher bar to reach. You have to lose even more kidney function to reach an endpoint and thereby show a benefit in EMPA-REG OUTCOME and VERTIS CV, whereas there was a much lower bar, only a 40% decline in GFR in these other trials. And so at EASD, which occurred about 12 days ago, we reported some additional analyses from VERTIS CV and tried to do more of an apples-to-apples comparison with a 40% reduction in GFR, renal replacement therapy, or death from renal causes in VERTIS CV with similar definitions across the other trials. And when we did that, you can see that the effects are much more consistent, including a significant reduction in VERTIS CV, which is in line with the other trials. So it might be that we originally used a definition that was too stringent, too much of a loss of kidney function, and it's also possible that the patients in VERTIS CV have different risk profiles for kidney disease, which may account for some of these differences. But nevertheless, an interesting area, and we're certainly doing additional analyses in this cohort on an ongoing basis, and we'll hopefully be able to show you some of those additional analyses very soon. So those are the cardiovascular outcome trials. The other trial, which was reported within the last 2 years, is CREDENCE, which was presented at the World Congress of Nephrology in Melbourne in 2019, and reported in the primary analysis a 30% reduction in the risk of end-stage kidney disease, doubling of creatinine, renal or CV death. And this is in patients with type 2 diabetes, a GFR between 30 and 90, and macroalbuminuria. So quite different than DAPA-CKD, which I'll tell you about afterwards. but this is a really landmark observation, and builds tremendously on top of the trials that I mentioned earlier, like IDNT and Renal, because 99% of these patients were on an ACE or ARB, and this benefit was shown on top of an ACE or ARB. So this builds on and clearly builds on our standard of care with RAS inhibitors. So our evolution in terms of the understanding of how SGLT2 inhibitors protect the kidney is, from my perspective, the following: that sodium appears to play a major role in mediating the effects of these therapies in patients and in animal models that were designed to elucidate the mechanisms that underscore and underlie renal protection with SGLT2 inhibitors. And in contrast, all of the data to date would very much suggests that the benefits of these therapies are either mostly or entirely independent of glucose, even though these were originally diabetes medications, quote unquote, due to their effect on glucose lowering. And by the end of this talk, what I hope I've convinced you of as the renal community is that these medications are renal protective therapies and cardiovascular protective therapies that happen to lower glucose as well, and that we all have to be very comfortable using them, understanding their side effect profile, and treating our patients in a safe but appropriate manner. So why am I saying that these therapies are glucose independent? So I'm going to give you basically 5 levels of evidence that underscore why these therapies are independent of glucose. And the first level, which is older data that we published in 2016, is based on the fact that the patients who take these therapies have about a 40% reduction in albuminuria when they take an SGLT2 inhibitor. This is data with empagliflozin, but there's data with dapagliflozin and canagliflozin and ertugliflozin that basically shows the same thing. So they lower albuminuria by about 40%. And what we showed in this analysis was that benefit, that reduction in albuminuria, was entirely independent statistically. So if we controlled for HbA1c reduction, there was no interaction between glucose lowering and albuminuria lowering. And there was also no interaction between weight reduction and albuminuria lowering. In other words, the reduction in UACR is independent of A1C change and weight change. And similarly, was largely independent of the reduction in blood pressure. So of the 40% reduction in albuminuria, only 9% was attributable to a reduction in systolic blood pressure. And similar data has been reported in patients with microalbuminuria. So the second way that we have come to understand that these therapies act independently of glucose is in studies where an active comparator was used. So in this analysis from the VERTIS program with ertugliflozin, we looked at the effect of ertugliflozin in blue and green compared to the active treatment group, which was a sulfonylurea, in gray. And what you can see is that there was absolutely a dip in GFR and then stability in GFR over time with ertugliflozin, whereas the active treatment with an SU group, they basically just lost kidney function slowly according to the natural history of the disease, even though A1C was the same in the ertugliflozin and non-ertugliflozin active treatment arms. And similarly, there was a significant and greater reduction in albuminuria in the ertugliflozin treated patients versus the sulfonylurea treated patients in gray, even though A1C change was the same by the end of the trial. Again, showing that there is this discordance between A1C reduction and clinical effects at the level of the kidney, here GFR and albuminuria. So then the third way that we know that these therapies act independently of glucose comes from trials involving patients with kidney disease. And patients with CKD stage 3B, especially and below, so CKD stage 3B and 4, these drugs basically don't have any effect on glucose. So although they do have effects on albuminuria and GFR and other factors that I'll tell you about, there is essentially no change in A1C over time once the GFR is below 45. And this data shows this very nicely. In this analysis with dapagliflozin, you can see that compared to placebo, dapagliflozin patients had this very nice reduction in albuminuria, which actually happens very acutely by week 4. and then is maintained over time, so that by the time patients are treated with these therapies for 2 years in this analysis, there was a reduction of around 30 to 40% in albuminuria, even though there was no change in A1C in these patients, highlighting this discordance between effects on glucose and effects on albuminuria, a surrogate marker of kidney protection. And similarly, in this analysis with empagliflozin, we looked at patients with CKD stage 1, 2, 3, and 4, and we showed, as you'd expect, because as GFR declines, there's less glucosuria, and so A1C lowering is attenuated and then lost by the time you get to CKD stage 3B and 4. You can see that there was a gradual loss of A1C reduction, but in contrast, as GFR went from stage 1 to 4, there was, if anything, a greater effect on blood pressure, which is thought to be mainly mediated by natriuresis. So the effects on glucose are lost as GFR declines, but other renal benefits around ACR, GFR, and blood pressure are maintained over time, and similarly, clinical renal protective effects are also maintained, which I'll tell you about in a moment. The final example of this discordance and loss of efficacy around glucose lowering with preserved renal effects comes from patients with CKD stage 4. And in patients with CKD stage 4 who were included in this sotagliflozin study, which is a less selective SGLT1 and 2 blocker, we reported this data at ADA and showed that there is this characteristic dip in patients with CKD stage 4. So these are the lowest GFR patients that I've showed you so far in this talk. They still have a dip in GFR followed by stability over time. And in addition to that, in patients with albuminuria at baseline, we also showed a significant reduction in urine albumin to creatinine ratio, at least in the 200 milligram arm at a year. So loss of albuminuria, loss of A1C lowering with preserved GFR and anti-albuminuric effects, even in CKD stage 4. And this is important because some of the trials in this field are involving people with CKD stage 4, and that includes DAPA-CKD, some of the other data with sotagliflozin, and the EMPA-KIDNEY trial that I'll mention to you afterwards. So these changes are highly clinically relevant for some of the outcome trials that are ongoing or have yet to report. So then the final area, and I think this is useful for nephrologists in terms of treating patients with these therapies, the last level of evidence comes from analyses from EMPA-REG OUTCOME with empagliflozin and from the CREDENCE trial with canagliflozin. And in the empagliflozin EMPA-REG OUTCOME trial, Mark Cooper showed that in patients who were included in this trial, so this is the risk of incident or worsening nephropathy, so progression of albuminuria, doubling of creatinine, renal replacement therapy, renal death. He showed that it didn't matter at the beginning of the trial if your A1C was less than 7 or 7 to 8 or 8 to 9 or greater than 9. All of these different groups of glycemic control, they all benefited the same. So there was no interaction between glycemia and ultimate outcomes from a kidney perspective in this trial. And similarly, Mark showed that it didn't matter what your change in A1C was. If you had a big change or a little change, bigger or less than 0.5% in A1C, bigger than or less than 0.3%, again, there was no difference across these different levels of glycemic control improvement. All of the patients in this analysis benefited, and you can tell that just for the students who are on the call. This is a p-value for interaction, and so this p-value of 0.5 shows you that this hazard ratio and this hazard ratio are not significantly different. In other words, both groups benefited to the same degree. This is similar data from CREDENCE in people with albuminuria and GFRs between 30 and 90 with type 2 diabetes. And again, for the primary outcome, end-stage kidney disease, renal replacement therapy, or CV death, no statistical difference across these different groups. You can see the p-value was greater than 0.05. And so all of those levels of benefit are the same across those different levels of A1C at the beginning of the trial. So how about in people with non-diabetic kidney disease? And this is an important question because in the studies that I've told you about so far, I've tried to make the point that glucose doesn't matter. So if glucose doesn't matter, then patients with and without diabetes should benefit to the same degree. So to test that hypothesis, Hito Heerspink and I designed and carried out this trial in collaboration with Sean Barber, who's based at your institution, and also in collaboration with sites in Holland and in Malaysia. And we randomized people with non-diabetic kidney disease to dapagliflozin or placebo for 6 weeks. We measured albuminuria, proteinuria, GFR, and a variety of other physiological parameters, and patients then washed out and crossed over. And the idea was that we wanted to prove that, one, that dapagliflozin reduces albuminuria in people with non-diabetic kidney disease, and we also wanted to prove that there are still preserved hemodynamic effects with these therapies in people who are not hyperglycemic. So people had to have, people who were included in this trial had to have 500 or more milligrams per day of proteinuria and a GFR more than 25. So the primary endpoint, which was proteinuria, I'm not showing you here, was neutral. There was no effect on proteinuria after a 6-week period of therapy. But what we did see was that there was still an effect on GFR. So the hemodynamic effect of these therapies, this is a measured GFR with iohexol, we saw a 6.6 mil per minute dip in GFR, which was acutely reversible. So pretty much exactly the same as what we'd expect to see in people with diabetes. We also saw a trend for a reduction in urine albumin to creatinine ratio, but this did not reach statistical significance. So preserved hemodynamic effects acutely, but no acute antiproteinuric effect with dapagliflozin in the DIAMOND trial. One final piece of mechanistic evidence I wanted to bring your attention to, because I think it's a really elegant study and was really not very easy to do, in people with non-diabetic normal kidney function, so normal kidney function, no diabetes. These investigators, so Zanchi et al. In the Journal of the American Heart Association, treated patients with empagliflozin or placebo and measured a variety of hemodynamic factors and also looked at BOLD MRI, which is a measure of renal oxygenation. And the hypothesis being that empagliflozin would improve renal oxygenation and thereby reduce the risk of fibrosis over time. So they showed in this analysis that there was an increase in glucose excretion, and we've reported that before, that people without diabetes still have a nice glucosuric effect. They also reported a reduction in blood pressure. They reported an increase in the fractional excretion of lithium. So basically this is done by giving a patient 300 milligrams of lithium the night before they come in for their test. You then measure, instead of fractional excretion of sodium, you measure the fractional excretion of that one dose of lithium. And lithium is handled in the proximal tubule. It's reabsorbed in the proximal tubule. So if you block proximal tubular sodium transport mechanisms, you'll also block lithium transport mechanisms, because lithium and sodium are reabsorbed by the same transporters in the kidney. And so they saw an increase in fractional excretion of lithium, showing that there is an increase in lithium excretion by blocking those proximal tubular pathways, i.e. SGLT2. They also showed a uric acid lowering effect, which is characteristic of SGLT2 inhibitors, and an increase in renin activity, which also happens with SGLT2 inhibitors in people with diabetes, because these are natriuretic therapies that induce a little bit of volume contraction, so that increases markers of the renin-angiotensin system. They did not, however, show a change or an improvement in renal oxygenation in these people, in these study participants without diabetes. So at least in people without diabetes, this very convincingly shows that there is no effect on renal oxygenation. And I'm sure the investigators are busily working away trying to look at this question in people A with kidney disease and B in people with diabetes and kidney disease. And I think that's the critical question to now ask and answer with this kind of elegant mechanistic work. So how about outcomes? So I've been telling you about people with diabetes and proteinuria and the effects of sodium versus glucose, as well as the physiology around what happens with these therapies in people who are not hyperglycemic. And I've suggested that there are preserved hemodynamic effects. I showed you that in DIAMOND because of the change in GFR, and I showed you that in the study by Zanchi et al. because there's still blood pressure lowering, there's natriuresis, there's activation of the RAS, which highlights that there's still physiological hemodynamic effects of these therapies regardless of ambient levels of glucose. But that doesn't necessarily prove what's going to happen in the long term in terms of outcomes. And that was, of course, the reason that DAPA-CKD was done. This study enrolled just over 4,300 patients with GFR between 25 and 75, UACR between 200 and 5,000. That translates to a UACR in milligrams per millimole of like 22.4. So sort of upper range microalbuminuria as the threshold to get into the trial, on a stable dose of an ACE or ARB, and they could have diabetes, and they were also allowed to be included if they did not have diabetes. Patients were randomized to dapagliflozin or placebo, and the primary outcome was the composite of sustained 50% GFR decline, end-stage kidney disease, renal, or CV death. And there are some secondary outcomes that I'll also tell you about. So for baseline characteristics, 62%, patients had a mean age of 62. There were a third of patients included who were female. For race, 52% were white, 5% Black or African American, 35% Asian, and 8% other. 2/3 had type 2 diabetes, systolic blood pressure 137, mean GFR was 43. Remember that in Credence it was 56 for the mean GFR. In the cardiovascular outcome trials, it was between 75 and 85. So this is a much lower level of kidney function versus the other trials. And UACR was 965, which is almost identical to what was recorded in Credence. 97% of patients were on an ACE or an ARB. So this is the primary composite outcome, which was, just to remind you, 50% decline in GFR, end-stage kidney disease, renal, or CV death, reduced by 39%, highly statistically significant, resulting in a very favorable number needed to treat of only 19 patients in this trial. So a very, very impressive number needed to treat. And with regard to components of the primary composite outcome, so 50% decline in GFR reduced by 47%, which you can see just over here. End-stage kidney disease reduced by 36%, and end-stage kidney disease components, including GFR less than 15 or dialysis, also significantly reduced. No effect on cardiovascular death, which you can see at the bottom. So I think this is the most interesting observation made in the trial, which comes from pre-specified subgroups, specifically people with and without diabetes. So people with and without diabetes, there was again no statistical heterogeneity. So this hazard ratio of 0.64 for people with diabetes and 0.5, so a 50% reduction in the primary outcome, was not different. In other words, the effect was similar. There was no heterogeneity around urine albumin to creatinine ratio above or below 1,000, and no heterogeneity around GFR above or below 45, so similar effects in patients with all of those different levels of renal risk. For secondary outcomes, there was a significant 44% reduction in the composite, a 50% decline in GFR, end-stage kidney disease, or renal death. The composite of CV death or hospitalization for heart failure reduced by 29%, and although cardiovascular mortality was not affected, all-cause mortality was significantly reduced, which you can see here, by 31%. So it'll be very interesting in further analyses to see what were those causes of death that were significantly reduced with dapagliflozin. For safety, so I talked about efficacy, safety also very important. No new safety signals, no imbalance in terms of amputation, fracture, major volume depletion, hypoglycemia, diabetic ketoacidosis, any of the concerns that have been raised either in previous trials or based on mechanisms in previous analyses, none of those signals were present or a concern in DAPA-CKD. So what does this mean for patients, and what do we tell our patients when we see them based on the results of Credence and DAPA-CKD? And I'm going to just give you some thoughts from the Credence trial, and this is this slide is courtesy of Dr. Levin. It's hard to discuss hazard ratios with patients because that is a bit of a hard concept to explain. But what we can explain is, what will you potentially derive in terms of benefits by being on a therapy like this in terms of being on dialysis. And for an average credence patient who's 63 years old, has a GFR of 56, with all of the limitations of this kind of modeling exercise, if we just extrapolate the slopes from patients treated with placebo or patients treated with canagliflozin in credence, it's been calculated that it would extend the survival that's dialysis free by about 15 years. So it's a huge benefit in terms of flattening the GFR decline rate in patients with diabetes. So it'll be very interesting to see if these kinds of numbers are also applicable to DAPA-CKD, and based on what we've seen, I suspect it will be, but I think these modeling exercises are important because it's a clear message that we can tell patients about. Whether it's 10 years or 20 years, I think it's hard to know based on the limitations of this kind of model, but it's information that we can give our patients that's possible to explain in a relatively brief clinic visit. So I've told you about credence, I've told you about DAPA-CKD, the other trial that is being carried out in multiple sites in around Canada, including in Vancouver and including in Toronto and other places that are actively recruiting patients for EMPA-KIDNey. This trial is also equally important because it includes people with lower kidney function, so GFR between 20 and 45, and in those lower GFR patients, you can have normal, micro, or macro albuminuria. And of course, in credence and DAPA-CKD, you had to have albuminuria to get into the trial, just like in IDNT and like in Renal. So EMPA-KIDNey will really provide unique data in this sort of data void that we have in nephrology. What do you do with a patient with low function but who has normal or microalbuminuria? Do these therapies have any benefit? And we truly don't know that information yet. So in those patients, please send those patients, if you see them, to Dr. Levin to be recruited into EMPA-KIDNey so that we can answer this question and help our patients in a data-driven fashion. However, in people with GFRs above 45, they do have to have albuminuria, just like in DAPA-CKD and credence, because that's the enrichment that leads to being able to capture benefits over a relatively short period of time. And EMPA-KIDNey also includes people with and without diabetes. So what's a nephrologist to do in terms of starting these therapies? And I had this precise conversation with one of my colleagues today. And after the conversation, I hope he felt more comfortable starting an SGLT2 inhibitor in a proteinuric patient who would benefit. But I think what we have to get used to is that these therapies do have different effects. They have effects on glucose and they have effects on cardiorenal protection. And if you're going to use it for metabolic effect, think about what the GFR is to be able to predict and anticipate what benefits will be around glucose lowering. And in patients with GFRs of more than 60, and some of you might not see a lot of patients with GFRs of more than 60, you expect A1C lowering to be about 0.7 to 0.9%. It's a reasonable effect, and there's also weight loss. But as I mentioned, as GFR declines, and at the other end of the spectrum between GFR of 30 and 45, there's an attenuated effect with no A1C lowering and an attenuated weight loss. So how about if you're not giving it for metabolic control, you're really giving it for kidney protection or heart failure benefits, which is the reason that I give these therapies most of the time. So I first take a look at their A1C and whether they're taking insulin or other agents that can cause hypoglycemia, like a sulfonylurea. And if their glycemic control is tight and they're on insulin or an SU, I tend to reduce the insulin dose by about 10% or reduce the dose of their SU or stop it. Patients like that, they're on one less medication, and then start their SGLT2 inhibitor once concerns about hypoglycemia are resolved. I have to say this happens, I would say this is in 5% of people who I see, so it's quite unusual to have to do this. So next I assess blood pressure, and if patients have normal or elevated blood pressure, almost all my patients, or if they're euvolemic or hypervolemic, then I just start the SGLT2 inhibitor. You don't have to worry about diuretics or other blood pressure medicines or ACE inhibitors or ARBs. These therapies can just be added on top of those background therapies. It's only in people who are taking big doses of loop diuretics with normal blood pressure where I sometimes will reduce the dose of the loop diuretic initially and then re-up titrate once I've started the SGLT2 inhibitor. And then in patients who are hypotensive or hypovolemic, also this will be obvious to all of you, you just back off on their other therapies and start the SGLT2 inhibitor once you're comfortable that their blood pressure is in a safe range, just like you would do with initiating any other therapy. So I'll stop there with the following conclusions and implications: that glucose lowering plays little or no role in cardiorenal protection with the SGLT2 inhibitors, that we really do need to stop thinking about obsolete GFR thresholds of 45 or 60. Please remember that those older thresholds that you probably heard about, that was because of glucose lowering when these were diabetes drugs. And as GFR falls below those levels, absolutely, A1C lowering decreases. But we're nephrologists and cardiologists and endocrinologists and family practitioners who care about preventing complications. And the GFR level in these patients has nothing to do with complications. So you can absolutely start these therapies according to what the trials did and according to what the labels did. And in Canada, we're fortunate because we can go down in most cases to 30, and I think the labels will almost certainly change now to 25, and maybe with EMPA-KIDNEY in the future, we'll go down to 20. And that's how we should be using these therapies for their non-glycemic effects and their benefits. SGLT2 inhibitors have pleiotropic effects beyond glucose. We know that from DAPA-CKD. We know that from other heart failure trials like DAPA-HF and EMPEROR-reduced. And so they're almost like an ACE inhibitor that has blood pressure independent effects. These are medications, SGLT2 inhibitors, that have renal protective effects that are independent of glucose in a similar fashion. And now we need to shift our attention from the data, because we have enough data to know how to use these therapies, to actually implement the results of the trials in our clinics. So I'll stop there and acknowledge all of the collaborators who have worked with me on some of the studies that I've mentioned, particularly acknowledge Sean Barber for his work in Diamond, and I'll look forward to your questions and discussion. Thanks very much.
Thanks, David, for really a great talk and for really updating us. I think we're very lucky to be able to hear firsthand from you. One of the questions that came up is, should we add SGLT2 inhibitors from early post-transplant periods in patients with and without diabetes? What would you say to that?
Yeah, great. It's an excellent question. So there's very little data that's been generated in this area to date. We published a small case series in 10 patients with post-transplant, post-kidney transplant, and showed that there were basically expected effects on blood pressure, weight, and no significant safety signals at the time. There's also an analysis in 50 patients with EMPA, looking at blood pressure lowering. Again, no specific safety signals. But I think we really have to wait for the trials to really guide us in a more evidence-based way. We are doing a heart and stroke funded study right now to gauge both the safety and efficacy in a small cohort. And in the future, we're going to try and get a larger clinical trial together to test this hypothesis. For now, because of the differences in a transplant patient, denervated kidney, single kidney, on a calcineurin inhibitor that causes afferent constriction and ischemia, I think we have to be very cautious. And if you're going to use them, it has to be clear that it's off-label and has to be in the hands of someone who's really very experienced.
Thanks. Others can ask questions by raising your hand or answering something. I think you would have mentioned it, but just highlight for us again what EMPA-KIDNEY will help us answer.
Yeah, so EMPA-KIDNEY is quite distinct in that it's going to add to the information we have in people with non-diabetic kidney disease, which is critical. Remembering that there was a relatively low number of patients with only a third of patients in DAPA-CKD and relatively few number of events. So it's important to add to that body of work with EMPA-KIDNEY. That's one. but especially the novel question that's going to be answered is this different phenotype of low function, so GFR down to 20, and people with normo or microalbuminuria. And this is a critical point that's not been addressed in any other trial to date, including IDNT and Renal and RAIN. These were all proteinuric patients, and so this is a data gap that we have, and we don't want to be in the position in 10 or 15 years where we're still saying, well, the drugs worked well in credence and DAPA-CKD in proteinuric patients. Let's also use it in people with normoalbuminuria. But that's not based on data. That's just extrapolating what we do with an ACE inhibitor. When I tell my fellows all the time, when I start a patient on an ACE inhibitor, if they have a GFR of 30 and 0 albuminuria, all I'm doing is either treating cardiovascular disease or I'm extrapolating from good studies that included albuminuria as an inclusion criteria. So I think it's a really important point that we have to answer in EMPA-KIDNey. And please, again, send your patients to ADIRA for recruitment into EMPA-KIDNey so that those patients can get evidence.
So I'm going to jump in. So VGH, St. Paul's, and Fraser Health are involved in as EMPA-KIDNey sites. I think it's really important just to sort of underscore what David's saying, that we change the culture of nephrology to not extrapolate because we're lazy, or like just to enroll our patients so we have the totality of data to treat all the people. If it isn't disease modifying in that group of patients, so be it. If it is, fabulous, but let's get the answer right. And so I think it's really important that, and let's not ignore the data that is already available from credence and DAPA.
Yeah, those are all excellent points, and I fully agree. There's another question from Dr. Zhang.
Yeah, any thoughts on studying SGLT2 for preservation residual for dialysis patients?
Oh, boy, I love that question, and I think that's a brilliant idea. And so the rationale, if I can just expand a little bit on what you're saying, Dr. Zhang, is that the effects of these therapies work at the single nephron level. And so even in a dialysis patient with a GFR of 3, we want to preserve those 3 mils per minute. And so by reducing glomerular hypertension in those patients with an SGLT2 inhibitor or an ACE inhibitor, or through whatever means, that could potentially reduce the risk of losing that residual kidney function, which we know has an impact on survival. So I think that's an outstanding idea. There aren't any really safety issues because these therapies are extremely safe and they would have less of an effect, if anything. So I think that's a great idea, and I think that's an important question to answer.
Especially given the high cardiovascular risk in our patients, and so the effects on myocardium as well as preservation of renal function, right? Like it'd be a twofer.
And nothing else works. So it's kind of like the transplant question. We extrapolate in transplant patients. We give RAS inhibitors because we think they might work, even though there's actually negative data, or neutral data, I should say, which doesn't show a benefit, and yet we still use them. We should be doing a trial with an SGLT2 inhibitor to try to preserve that single kidney, that single denervated kidney. We should try to develop a novel modality of preserving it. So I fully agree.
Yeah. Any additional questions? I appreciate for David, it's late, it's 5 to 9. And there's another question coming to the chat box. Do you think there should be a role for SGLT2 inhibitor use without RAS inhibition?
Yeah. Sure. So that's an excellent question. So I suspect that we'll have some data around that from EMPA-KIDNey. So patients with lower GFR, remembering that the lower bound for EMPA-KIDNey is 20. So there are going to be a lot of patients who are not on a RAS inhibitor, and they don't have to be on one for EMPA-KIDNey. So that's a common question that we get. Do they have to be on a RAS inhibitor? And the answer is no, because we can't treat our patients. Some patients can't tolerate it because of hyperkalemia or rapid GFR decline or hypotension, and so they are not on an ACE or ARB, and this would be an alternative. So that's going to be a very important question to look at, even if it's just looking at it in terms of statistical heterogeneity. Is there a bigger or lesser benefit in people who are not on a RAS inhibitor? That's a critical question. But doing a trial in people with looking at without a RAS inhibitor, what study would we need for that patient with a creatinine of 200? UACR 60, high K, low blood pressure. Those are all very important points, and this may be a role for an SGLT2 inhibitor alone. But it brings up the question: should we be doing a trial in people with who can't be on an ACE inhibitor or ARB uniquely, and to prove that point, because there is absolutely clinical equipoise in that area.
And I just, point out there is the Lancet Diabetes Endocrinology article where they actually did a meta-analysis, and the effect was similar off and on RAS inhibition, but it doesn't replace Linda's question, which is if you can't be on a RAS, could you try? So I think it's a great question. And then there's another question.
If these drugs
they're working because, I see it. If they're working because of their natriuretic effect, why do we not see the same outcomes with other natriuretic?
Yeah, great point. So it's so all natriuresis is not the same. So a natriuretic drug such as an SGLT2 inhibitor works in a very particular part of the kidney, which is the proximal part of the nephron. And that's as compared, and we'll just take a little stroll down the nephron for a minute. That's as opposed to a spironolactone, a mineralocorticoid antagonist, which is distal. So a distal therapy does not increase delivery of salts to the macula densa, which is the area that's responsible for triggering tubuloglomerular feedback, changes in renal function, changes in albuminuria. So that's why spironolactone effects are neutral around kidney function and albuminuria. For a thiazide diuretic, it's again downstream from the macula densa, so it doesn't have these SGLT2-like effects. Lasix is kind of a standout because you'd think it's upstream. So if you increase delivery from the loop of Henle, that should trigger the same SGLT2-like pathways. But do recall that the way that sodium gets into the macula densa cell is through the Lasix transporter, the NAK2Cl transporter. So Lasix blocks its own entry into the macula densa, and there are beautiful studies by Avi Shaniak and others who have given doses of loop diuretics, tiny little doses of loop diuretics that are targeted to trigger TG feedback, and they do nothing to GFR or albuminuria. And it's thought that it's because that the salt can't get into the macula densa cell to trigger those effects, because it sort of closes the door on itself, so to speak. But the one diuretic that's similar to an SGLT2 inhibitor is acetazolamide. And acetazolamide is super cool because there are studies by the same fellow, by Avi Shaniak, who's given equipotent doses of acetazolamide versus a loop diuretic, and has shown that acetazolamide causes a reduction in hyperfiltration. Why? Because it's a proximally acting diuretic and triggers the same TG feedback by increasing the delivery of sodium to the macula densa, whereas Lasix in the same study did not have that effect due to its closing of the transport door. So that's why these therapies are extremely different. Now, from an empirical perspective, I do want to just raise the point that there aren't the same kinds of studies that have been done with furosemide or the other diuretics that I mentioned, with the exception for mineralocorticoid receptor antagonists, which were used in the Fidelio trial that'll be coming out soon, I hope. There aren't good thiazide or loop diuretic or acetazolamide trials to disprove or to show that they don't have an effect. But from all we know from first principles, they act distinctly physiologically and don't have that kind of effect.
Thank you. Well, I think everyone will agree this was really a fantastic way for us to spend our pre-dinner hour and you to spend the post-dinner hour. Really fantastic. And thank you very, very much, and to all the participants for your excellent questions. And maybe we should design a large pragmatic trial of people on dialysis in BC receiving a fixed dose of SGLT2, who knows, but we'll work with you on that. And very much appreciate your time and respecting everyone else's. Thanks. Remember to put in your evaluations, everybody. And if you have patients who qualify for EMPA-KIDNey, send them to the various sites, the 3 sites in the Lower Mainland, and we'll help to answer these other questions. So again, David, thank you very much.
Thanks for inviting me. I appreciate it. Have a good night, everyone. Take care.